Well, we know on average that when women have progressed on first-line endocrine therapy, the median progression-free survival unfortunately remains under a year. So we really want to think about, again, incorporating a targeted agent with the anti-estrogen therapy or participation in clinical trials. So what I would tell this patient is if I was to start her on anti-estrogen such as exemestane in combination with everolimus, that at least when it was studied with that combination in the first line setting, the median PFS, there's different endpoints, was about 10.6 months compared to 4.1 months when the anti-estrogen was used alone. I'd also tell the patient that there are added side effects when you add everolimus, and these include mucositis and other things like anemia and a very rare form of lung irritation, inflammation known as pneumonitis. So I think with everything we do in cancer, we have to highlight the benefits, which is if we add this pill, it will make your anti-estrogen work better, but also highlight the possible side effects. So just to summarize what I would tell the patient is I think we should use both pills, the combination of exemestane and everolimus. It has this benefit of adding about 6 months longer to how long the drugs work. There are these added side effects. We'll have to monitor you closely. At least in my practice, when I started, I see the patients 2 weeks into it and 4 weeks into it. So it makes it very similar to the monitoring requirements that we see with other targeted agents. Just because I think patients, when they go home with the pill, think, oh, I don't need to call the doctor because it's not chemotherapy, but I really try to educate the patients up front so that they don't get into trouble with the side effects. And I would tell the patient I think it's worth doing.